right, so we're going to finish up the respiratory physiology. Any questions from the stuff we covered last time? Nope. All right, let's talk about acid-base balance of the blood. Right, so again, how are we maintaining our acid-base status in the body? Kidneys are important. What else? The lungs are the other big place, right? Because lungs are going to do what for us? They're either going to blow off carbon dioxide, or we can hold on to carbon dioxide. Or in the case of the kidneys, what can happen? Yeah, we can either get rid of bicarb. In some cases, you may have some hydrogen ions being escaping from there. But yeah, so which one do you think is faster? Respiratory is always going to be faster than the kidneys. Kidneys are usually going to be sort of a compensatory sort of thing to try to catch up with whatever other changes are going on there. So that's one thing to remember. pH range of the serum should be 7.35 to 7.45. However, say for instance, that was on the arterial side. If you checked on the venous side, what would you expect to see? Should be more acidic, more basic? Should be more acidic because we picked up CO2 from the tissues, right? So again, you would expect a VBG, or venous blood gas, would be a little bit more acidic in that case because you picked up more CO2, right? And again, we know that we can buffer the system by having that conversion between carbon dioxide and water. Carbonic anhydrase will change that over to carbonic acid. That can then dissociate into hydrogen ions and bicarb, right? So again, bicarb is one of those things that you'll see on your Chem 7, right? That's an important thing to look at because that will tell you kind of what the acid-base status is going on in those cases there, right? Now again, we're going to call that a volatile acid. We have that carbonic acid because again, it's volatile because we can get rid of it, right? We can change it into CO2, breathe it off, get rid of it. There's going to be non-volatile acids. That's going to include things like lactic acid, fatty acid. So if you have like someone like a diabetic ketoacidosis or something, they're producing a lot of ketone bodies and whatnot, they can't really get rid of that as easily as you can something like carbonic acid, right? So again, those are going to be considered non-volatile acids, usually going to be more regulated through the kidneys for the most part, right? Okay, so say acidosis is going to be when that blood pH falls below 7.35. And so there's going to be two varieties of that. You can have a respiratory acidosis and a metabolic acidosis. I'm sure you've covered this to some degree already, somewhat. Okay. Usually respiratory acidosis is related to hypoventilation, right? So again, we're breathing more slowly, or maybe we're breathing more shallow, and we're going to find a buildup of CO2. When I have a buildup of CO2, that's going to drive that reaction over to producing more hydrogen ions. That's going to make us more acidic, right? pH should go down in those cases. On the other side, you can have things like a metabolic acidosis, which is either due to production of excessive acids. So say, for instance, you have like a lactic acidosis or a diabetic ketoacidosis. Those are two ways you can have metabolic acidosis. Or the other case could be you're losing bicarb, right? So for instance, if I was having, say, severe diarrhea, or if I was having something where the kidneys were losing a lot of bicarb, that can also cause the pH to drop, okay? So in the lungs, mainly it's just CO2 buildup. On the bodies, or the more metabolic side, it's either going to be production of acids or loss of bicarb. You can have alkalosis when you get above 7.45, and so that's usually going to be caused by hyperventilation from the respiratory side. So if you have a respiratory alkalosis, you're blowing off a lot of CO2, and that's going to cause the pH to rise, as you might imagine. Hydrogen ion concentration is going to go down. I see this a lot when I run into someone who has an aspirin overdose. Aspirin is a drug that actually will directly stimulate the respiratory drive, and so one of the first things you'll see is tachypnea in those patients, right? So fast breathing, and they will actually blow off a lot of their CO2. So I can actually diagnose an aspirin overdose with just an ABG rather than actually needing an aspirin level in some cases, right? So there are some things you can use to look at that. On the metabolic alkalosis side, usually it's either going to be due to inadequate production of acids, or you're going to find that you have maybe an overproduction of bicarb, or in some cases you're having a lot of vomiting, you're losing a lot of stomach acids. That could be one case where you're trying to tip the balance and induce a metabolic alkalosis, right? So which one do you think is kind of more common to run into, an acidosis or an alkalosis? Usually acidosis is probably a little bit more common to run into, both on the respiratory and on the metabolic side of things. And notice here when we're actually trying to diagnose what's going on here, you're going to be looking both at the bicarb level within the serum, right? And you're also going to be looking at the PCO2, right? What is PCO2? Is that partial pressure carbon dioxide? Again, this is going to be on the arterial side of things, because again, we'd always assume that on the venous side we should have a higher PCO2 in those cases, right? So, usually when I'm looking at a PCO2, usually things somewhere like 35 to 45 I consider to be somewhat normal. So again, there's always going to be a little bit of a range there. Usually with like bicarb, like 21 to 28 or so. And again, if I put a value on the test, I'm going to include what the reference ranges are going to be as well. So you don't have to necessarily memorize those numbers. You'll get familiar with them though as you encounter this stuff more frequently, right? But by using these, by looking at the pH and by looking at these two values here between the bicarb and the PCO2, you can try to diagnose whether or not it's a metabolic issue or it's going to be a respiratory issue. And then you can also detect whether or not the other system is going to be compensating for that. So for instance, if I have, say, a respiratory acidosis, what does the body want to do to compensate? A metabolic, again, homeostasis, negative feedback loops. Well, it's gonna try to induce an alkalosis, essentially, right? So there's multiple ways that can happen, but basically, if you have an acidosis on the respiratory side, the body wants to compensate with an alkalosis on the metabolic side, right? Or in vice versa, right? So for instance, if I have someone who has a metabolic acidosis, the lungs are going to do what? Cause a respiratory alkalosis, right? I'm going to start to blow off more CO2, right? That's one of the main ways you're going to see that correction occur there. So again, if one is abnormal, the other one's going to try to compensate for that, right? And again, we can do that within certain ranges, but at some point you can tire out the system essentially, and that's where you can have kind of either overwhelming alkalosis or acidosis, as the case may be. Okay. So again, looking at this, you can refer back to this. We already discussed this in a large amount, but whenever we say compensated, what do you think that means? How could you tell if the system was compensated or not? Say it again? Yeah, so yeah, basically that means when we're compensating, we are bringing it back to baseline, and you can look at that at the pH. So if you have something where you see the PCO2 is really off and the bicarb is really off, but the pH is normal within that 7.35 to 7.45 range, that's considered to be compensated, okay? So again, you can compensate to a point, but then eventually you're going to kind of overwhelm things to some degree, okay? So we'll go into more detail on that in just a little bit. And again, I'm not going to belabor the Henderson-Hasselbalch equation. You guys already scarred enough from farm, I'm sure, after looking at this. But again, this is how we're kind of figuring out, you know, the ratios between bicarb to PCO2. That's how we're actually getting our pH, as the case may be here. But again, it's always going to be a balance here. If I have more bicarb, I'm going to make the system more alkalotic. If I have more PCO2, it's going to make the system more acidotic. Okay. So again, when I'm looking at the acid-base balance, when I have hypoventilation, you're going to expect to have a buildup of CO2, because again, I'm not going to be blowing off as much as the case may be, and so you're going to expect the carbonic acid levels to be high as a result of that, and so you expect respiratory acidosis. Again, on the flip side, when you have hyperventilation, so you're going to have a lot of blow off of CO2, those PCO2 levels should drop, and you're going to expect to see a respiratory alkalosis occur in these cases, right? And again, when you're looking at the ventilation to compensate for things, right? So we can try the ventilation can compensate for the metabolic aberrations that happen here. So for instance, if you have a metabolic acidosis, as I mentioned, you usually will see that the patient will start to hyperventilate to try to blow off more of that CO2, right? So again, as the hydrogen ion starts to decrease, you're going to find the pH will then rise up, and then that negative feedback will be enacted essentially, and then you'll see the breathing rate start to go down again, closer to normal. If you have someone with the metabolic alkalosis, what do you think the breathing would do? The ventilation would be increase, decrease? Should be decrease, right? Because again, at that point, you want to hold on to more CO2. So you probably have, say, something like bradypnea occur, right? So be slowing down your breathing in those cases, okay? So basically what you can do is look at things like, okay, well, let's look at the normal pH. Let's look at a normal, say, PCO2 level. And here they put, say, 39 to 41. Usually on labs, you'll find that the range is probably going to be a little bit wider. It's like 35 to 45 is usually pretty normal. But in this case here, you'd see, you know, ventilation would be normal. Again, there's no need to activate any of those negative feedback loops in those cases there. However, let's say, for instance, we have a respiratory acidosis. You expect the pH to be low, right? So say, for instance, someone, you know, had an injury, or they maybe drink too much alcohol and they stop breathing or slowing down their breathing pretty significantly. In those cases, pH would be low. PCO2 would be elevated, right, because they're holding on to more CO2. And in those cases, you typically be hypoventilating, because again, they're not breathing quite as quickly. And so again, in this case, you'd find that this is the cause of the acidosis, right? So again, I'm linking back the fact that I'm determining that I'm acidotic, right? So maybe I'm 7.1 or 7.2. The PCO2 is high, and they're hypoventilating. That's telling me that this is a respiratory acidosis. That makes sense? On the other hand, let's say you have a respiratory alkalosis. You expect the pH to be high, right? And then you expect the PCO2 to be low, because again, they're hyperventilating, so they're probably blowing off a lot of CO2. In this case, you say, okay, well, this is the cause of the alkalosis, okay? Now, things get a little bit more tricky when you're trying to determine whether the ventilation is trying to compensate for metabolic issues here, okay? So let's say, for instance, I have a metabolic acidosis. The pH would again be low, right? And then at this point, the PCO2 would be low. But why would that be the case? the lungs are trying to compensate. So I'm trying to blow off a lot of that CO2 in order to get rid of that extra acid in order to bring the pH back up. Okay, so in those cases, the metabolic acidosis, the patient may be hyperventilating, and that is going to cause pH to rise. And so in this case, the lungs are compensating for the metabolic acidosis. Okay, so again, you might have like a patient vignette on the test where it's trying to assess a patient. You're going to see the pH, you're going to see the PCO2, and you're going to see the bicarb. And your job is to figure out, okay, well, one, is this compensated or not? And how do you determine if it's compensated? Is the pH normal, right? Is it within the reference range? If not, then you know it's not compensated, right? And then you're going to be looking at the PCO2. If it's high and the patient's acidotic, then you know it's a respiratory issue. If it's low and the patient's acidotic, then you know it's going to be more of a metabolic issue. Okay, so you can kind of get comfortable looking at these and kind of working through these problems like this, because you might see something like that coming up, right? Anyway, metabolic alkalosis, you expect the pH to be elevated, right? And then in this case, the PCO2 would be high, because the lungs are trying to compensate, right? So the lungs are going to hold on to more acids in order to try to compensate for that metabolic alkalosis, okay? Make sense? So again, try to think through it. Think about all the different changes that are occurring here when the body's trying to compensate for either of these problems here. Okay. And again, just know that when we get to the renal physiology, you're going to see that the kidneys are going to be another big place we're going to be causing slower compensation, but it does occur. So a really good example, and I mentioned this already, is aspirin overdose, and kind of how those patients' acid-base status actually evolves over time. And so one of the things I see with an aspirin overdose early on is that they will have their respiratory drive stimulated, right? So in this case, they're going to be hyperventilating, and that should cause what? Respiratory alkalosis, right? Because they're blowing off a lot of CO2, right? So, okay, so they're blowing off all the CO2, have this respiratory alkalosis. Well, then how would the kidneys want to compensate? They want to get rid of bicarb so they can induce a metabolic acidosis to compensate for the respiratory alkalosis, right? So at that point, the kidneys start to release a bicarb, and you can measure the urine pH and determine whether it's alkalotic or not. Usually it will be. And so, okay, so now they're compensating, right? So you think everything's good to go, right? Except what you find out is that aspirin actually helps to uncouple oxidative phosphorylation. So you actually inhibit the ability to produce ATP through aerobic respiration. And what do you think that causes? Because if I have to go to anaerobic metabolism, that generates what? Lactic acid. So the patient would develop a metabolic acidosis in this case, right? So now they have a metabolic acidosis. They peed out all their bicarb. So now they're even worse on the metabolic side. And then eventually they're going to tire out from the respiratory side, and then they have this overwhelming metabolic acidosis. So again, you can find patients will evolve over time depending on how the disease state is progressing in those cases. Yes, sir. No, so the aspirin itself is actually causing the respiratory drive to speed up, right? So it's actually, say for instance, like starting to activate like that apneustic center, right? So it's trying to activate that, and you're going to see that increased rate of breathing, and so that's what causes the respiratory alkalosis, right? Even though aspirin's a weak acid, it's not enough to really throw the system off, so to speak. Initially, yes, and then later on, when they're at a point where they're developing that metabolic acidosis, the lungs are then going to want to compensate, but they've already blown off all that CO2. They can't really do anything about it at that point, right? So they can try as hard as they want, but that metabolic acidosis just takes over, and now all of a sudden they're uncompensated essentially, right? And that's usually when they go down the drains, so to speak. Okay. So again, kind of work through those, kind of see how those changes will occur. Again, focus mainly on the respiratory side of things because that's kind of what we're covering now, right? Okay, let's look at the effect of exercise. Now, typically during exercise, O2 consumption is going to go up or down. You would expect to go up, right? Because again, you're needing to deliver all that oxygen to the muscles, so that way you can produce new ATP, all that good stuff. CO2 production should consequently, well, it should go up as well, right? Because again, the byproduct of glycolysis and aerobic respiration is what? Heat, CO2, and water, right? So there's byproducts there. That's what's caused. So we're going to see CO2 production go up. We're going to see O2 consumption go up as well, right? So again, I need to deliver more oxygen into the muscles. I need to pick up that CO2 and get rid of it as well. That's why, again, when you're exercising, what does your respiratory rate do? It usually goes up, right? Unless you're extremely fit and you can run a marathon and have a normal respiratory rate. But most people aren't like that, right? Some people are huffing and puffing just getting up, a flight of stairs, right? Not that I'm like that or anything. Anyway, should probably take the stairs more, but So anyway, so again, this is called hyperpnea. So hyperpnea is going to be kind of more that increased volume of breathing, and then tachypnea is the actual rate of breathing itself should be going up during exercise, right? And again, you'd expect things like heart rate to go up as well, because again, that's going to increase cardiac output to try to get that blood flowing to all the organs where it's needed at the time. However, what you're going to notice is that, you know, the actual PaO2 levels, even though they're being used up more, you actually find they're able to keep pretty steady levels for the most part, because again, everything can compensate up to a point, right? Okay. So again, during exercise, you'd expect ventilation should be increased. The blood gases actually should not really develop much changes there, because again, even though you're increasing the rate that you're eliminating CO2, the production of CO2 has also gone up about the same amount essentially, right? So everything is being kept in balance. So you should not see the blood gases change dramatically. However, we are still delivering more oxygen to the tissues, and we're still pulling out more CO2 that's being produced there. Make sense? Again, always to a point, because again, I can have too much exercise or too much physical exertion into a point where I'm not able to compensate anymore. So, for instance, you imagine, you know, people who have dyspnea or like, you know, dyspnea on exertion. That's usually going to be because they cannot compensate for that. They cannot keep up with that O2 demand being delivered to the tissues because maybe their pulmonary system's not working appropriately, right? So, kind of keep those disease states in mind. Okay, and then looking at the effects of altitude on delivery of oxygen to the tissues, we're going to see here that obviously as you get higher up in altitude, you're going to notice that the PO2 in the atmosphere should do what? It's going to go down, right? And then you're going to start to see that you're going to have a consequential decrease in the PO2 of the actual arterial blood itself, right? So we're going to find that there's some ways we can actually compensate for that. There's going to be some things that happen kind of immediately, and there's going to be some things that are going to take a little bit more time to occur here, right? We already talked about one way that we can compensate for altitude, and that's what? Yeah, produce more hemoglobin essentially, right? So how do we stimulate that? Erythropoietin, right? And that's stimulated, or that's produced by kidneys. Good, right? So again, if you have really bad kidneys, you may not be able to compensate. You may not be able to produce that erythropoietin. That'd be one way they could not be able to compensate if they moved from, say, Florida to you know, Denver. So the immediate response, so say for instance you went from Florida to Denver, hopped off the plane, the immediate changes you're going to see there are going to be the fact that your body is sensing that there's a decreased amount of PO2, right, in the atmosphere, and that's going to be stimulating the carotid bodies to increase ventilation. Remember we said that the carotid bodies are going to be more sensitive to the O2. Again, CO2 is always going to be the most primary drive there, but here the CO2 is not the issue. It's the lack of O2 in this cases. So the carotid bodies are going to be picking that up. They're going to increase ventilation, so that already should be increasing the amount of oxygen you're going to be picking up there. You're also going to find the hyperventilation lowers PCO2, and that can actually induce a respiratory alkalosis. Okay. Now remember, going back to Bohr's law, remember what happens as you cause that alkalosis. What does that do to the affinity for oxygen to hemoglobin? Does it shift it right where it favors unloading, or does it shift it left where it favors loading? More alkali, it's going to shift left, and you're going to see that it's actually going to be favoring picking up the oxygen in those cases, right? So in this cases, what you're going to find is that the respiratory alkalosis will increase the affinity for hemoglobin to oxygen. You're going to be binding up more of that oxygen in the lungs, right? So maybe you go from that 97% that you normally be sitting at up to maybe closer to 100, essentially. You're picking up more O2, so that way you can deliver more of it over to the tissues, right? Over the next couple of days, there's going to be some other changes that occur here, because again, things like erythropoietin, they can be stimulated early on, but it's going to take time, right? Just like hormones, they usually are pretty slow to work in comparison to some other things like, you know, neurotransmitters or something. So over the days that occur after that change in elevation, you're going to find you have this 2,3-DPG. And this is basically going to be this reaction that occurs in the red blood cells that actually favors that conversion from oxyhemoglobin to deoxyhemoglobin, right? So that's that unloading process that occurs here. So not only do I have this early respiratory alkalosis that favors picking up more oxygen in the lungs, but now I'm having this change over the next couple of days that favors dropping it off into the tissues, right? So I'm being more efficient with the amount of oxygen I'm actually carrying like hemoglobin, because more of it is going to be unloaded onto the tissues, right? Because that's what changes over a few days or so. And then finally, over the course of weeks, that's when the kidneys are really going to come into play here. This is where we're going to be stimulating erythropoietin. We're increasing the amount of hemoglobin that we have here. Also, what do you need in addition to that erythropoietin to produce new hemoglobin? Good iron, B12, folic acid, thiamine, all those good stuff, right? So you need all that stuff in the diet to make sure that you're able to produce that actual hemoglobin. Because again, if you don't have good iron stores, if you don't have any of those precursors, it doesn't matter how much erythropoietin you have, you're not going to be able to fix your issue there, right? And again, having more hemoglobin, that means more oxygen can be held onto. That means you have more oxygen dissolved in the blood, right? Okay. And again, you can go through this here, but just know that what the immediate changes are versus the process that occurs over a few days versus what happens over the course of weeks. Okay. So that is the end of the respiratory section. Any questions you guys may have? No. Whole section 2. And any questions on any of the other stuff we covered? All right, so again, you'll have the videos you can go back and review. Again, they'll be available for questions. I'm sure it's going to be a busy weekend. You guys studying and getting ready. I will not be here Monday. However, I will be here with you in spirit, as I mentioned. We're going to do the Kahoot review, okay?